Well, Dr. Felipe Vega. Vega, would you like to comment to the case? Well, feel free to raise your hand and put perhaps your comments on the chat, and we can, call you if you really want to make a comment on the case. Okay, let's start. I'm going to
Sounds good.
just share the screen. Right. I'm not sure I'm able to. Well, I'm doing this or not.
We see your screen now, yes.
Okay, that's
yeah,
it.
there you
go. Here we are. Okay. Are you seeing the presentation or not?
Yes, it's
go.
perfect.
Yes.
Okay, so let's start. First of all, I'd like to thank Dr. Antonio Martos and Dr. Menegoso for the invitation for participating in this meeting. The first Monday of the month is a Monday that is for SBITE cases. So the Brazilian Trauma Society was invited to participate and bring the cases. And I'm very happy to share with you this. This is the case where the hospital where I have the majority of my activities. It is the Santa Casa School of Health Science in São Paulo, Brazil. We have here the departments of surgery. We have the emergency service, and of course, this is from the emergency surgery. It's about a male, 50 years, brought to the hospital by his relatives due to a stab wound in the chest. There was some kind of fighting. Nobody would really say what happened, but they brought him by themselves. So it was a clear aries, respiratory rate of 20, with bilateral chest sounds and a saturation oxygen of 96%. Heart rate of 104 beats per minute. He had a good perfusion, a stable blood pressure, no external bleeding. His heart sounds are normal too. Glasgow Coma scale of 15 with no neurologic deficits, and he sustained this wound in the chest. Okay, are you seeing my arrow here?
Yes.
Yes.
Okay, that's perhaps 2 centimeters long. Nipple. This is the xiphoid, and the here is the costal margin. Okay, don't ask me what this is because probably it's too long ago. I don't just remember. But this is the wound. I'd like to hear the comments. Let's start perhaps with Dr. Pust.
Yes, what we always do, obviously, is primary survey, secondary survey. I already mentioned that he seems to be fairly stable. Also, he is a little bit tachycardic. So, but you clearly have a stab wound in the cardiac box. The other thing, what's important to mention is to look for other injuries, right? You may think it's just one stab wound there, but he may have another one on the back. So it's important to turn the patient, get all the closing off, and look everywhere, make sure there's no additional stab wounds than this one. And then what I would do next is a fast exam. Look with the ultrasound to see if there's any signs of pericardial effusion and any signs of pneumothorax, lung sliding on fast exam. I would also consider chest X-ray because if he does have a hematothorax on chest X-ray, the fast exam is less reliable in ruling out a cardiac injury. So in that case scenario, we would need to consider other steps.
Okay. Would you worry about a diaphragm injury also or not at this point?
In general, yes. Any left thoracoabdominal stab wound has the potential to cause diaphragmatic injuries. So that's also a concern.
Okay. Let's go ahead. That's what it did. The fast was negative, both in the pericardial window, and at that time we didn't do the lung window. So it was a negative chest X-ray and a negative pericardial and abdominal windows. Okay. Next steps. Let me ask other panelists, perhaps Dr. Collet. We have this stab wound, a stable patient, and normal labs too. ABGs and labs were normal.
Yeah.
And then what do you do? What do you do, Collet? Yeah, Wi-Fi is not good, really, indeed. Sorry, Francisco.
Gustavo,
Yeah.
I think you have a stab wound in the injury in the heart, maybe in heart, or maybe in diaphragm, maybe in chest. It's a penetration wound in the Zidler area. You have a negative fast. It's not absolutely discharge any heart injury. So I think in this patient, maybe start especially stable, you can go to a CT scan, angio CT, to see if there is some effusions in the chest, some fluids in the abdomen, some air in the abdomen, or pneumothorax or hemothorax, or pneumopericardium. Sometimes you may have when you have injuries in the chest in this area. So
Okay.
I think this patient need to be monitoration, and then you can go. In the first exam, you can go to a angio CT, and then you can sometimes use a echocardiogram, a complete echocardiogram. Different, yes, can be used. May be useful for see the heart and the pericardium. So I think for us it's very easy to take a CT, angio CT. At the moment,
Okay.
I try to make it. Okay.
So to try, we lost your signal for a while, but to understand, you do a CAT scan, and
Yes.
even if you complete it with an echocardiogram. Of course, we are
Yes.
going to do both, not only one.
I think you can go first. For us, it's very easy to make angio CT. The angio echocardiogram is more difficult. Sometimes you have to not have it disponible in the emergency room. So I think okay.
Okay, Dr. Collet, thank you very much for that. And people from Ribeirão Preto, what do you think about it? Would like to comment, Dr. Stassetti?
We agree with Dr. Collet. Angio CT is the next step.
Would you think it is obligatory to do any let's say the CAT scan is negative, Luis. Would you think only the fast exam and a negative CAT scan would rule out a cardiac injury or not?
No, we can exclude.
And how do you manage it?
We have already seen patients with cardiac injury that the manifestations occurred hours after, one day after the arrival, and so we have to maintain a close we have to take care of in a intensive care unit.
You know, Luis, I'm much younger than you, much younger than you, but there were times these patients were, taken to the pericardial window, a subxiphoid or something like that. What do you think about this? Would you do that? Do you manage to do this in Ribeirão Preto, or pericardial window is just another thing in the past? What do you think?
Not as a diagnosis procedure. Yeah.
Okay. Dan, do you have any ideas about the pericardial window in this case, or would you wait for the other exams?
Yeah, so our standard is, stab in the box pericardial window. We're still pretty conservative. But if he's perfectly normal, I would, what Dr. Collet said, what I do next, I would get a formal echo. And I think if the formal echo is completely negative, it's probably not unreasonable in the year of 2025 to say I'm going to monitor the patient and maybe do a repeat echo or only intervene if it becomes symptomatic. I certainly wouldn't say I have a negative echo, negative chest X-ray, and send them home. But our standard has been for many years and probably still is to do a window. So if you want to really truly rule out a cardiac injury, you would need to do a pericardial window in this case.
Okay, no, you know, that's exactly our point. In our service, we do exactly the same. We do the echo, negative echo. In these cases, would rule out. We would be worried about the diaphragmatic injuries, which should be a problem. But let's see how the case goes. Let me put it here. Well, we complete the secondary survey without additional findings. Admission for observation, monitoring labs, and vital signs. We asked for echocardiogram, a CAT scan, and we were discussing about the necessity of doing a VAT, video assisted thoracoscopy, or video laparoscopy. And so the result of the echocardiogram went different from what we believe. The labs were pretty okay. 100 okay. I understand 100 beats per minute is not normal, especially for young patients, but you have a stable pressure. The respiratory rate of 20. ABGs came back normal. The second X-ray was normal too, but they have this echocardiography with a small amount of fluid in the pericardial sac. Also, the echocardiographer said that it was a normal cardiac function with no signs of tamponade. And this is the moment I'd like to hear you again. You have this finding. What is the best choice for the patient? What do you do in your services? What do you think maybe via an option in the future? What do you think about this? Let's start with Dr. Collet. Francisco, Chico Collet, can you hear? Sorry, I'm just not seeing you well.
Yes, sorry. Yes. Okay. Parreira, I think in this activity to see fluid in the pericardium, you have some physiological fluid. So sometimes maybe no blood in the pericardial sac. It's only a patient that you show us. Maybe sometimes of some pericardial fluids and not blood. So in this situation, you can see the patients, because when you see the patients, you can see the patients maybe use more alcohol, some ethylism. So I think these patients maybe some cardiac problems or some injuries associated with injuries of the alcohol. So I think it's important. If the patients become some unstable or sometimes this increase this fluid, I think these patients need to go. You can go to a pericardial window by substitute pericardial window. Sometimes you can go. I don't think it's this patient is too unstable. Maybe justify. You can put in the thoracoscopy a VAST to make a pericardial window through the VAST. And sometimes maybe not important because not signs of abdominal injury. So you can next day, if you suspect that the patients have a diaphragm injury, you can put these patients to a laparoscopy to see the diaphragm. It's maybe not in this moment. At this moment, I think it's important to observation the patient and the signs and repeat the echocardiogram in 6 or 12 hours. If it's increased or the patients may have hemodynamic instability, I go to make a pericardial window and then or if it's necessary a thoracotomy or not. Okay.
Okay. So you think this small amount of fluid is physiologic and it's not related? Maybe.
But I don't know.
You'd be okay observing. Would you go to a pericardial window or at this moment or not?
No, in that moment, no. I think when we see fluid in the pericardium by ultrasound, sometimes maybe a physiological or complications of some cardiac injuries that the patient has. So although you have the injuries in the chest, maybe you can think about this. Next time you see a patient with pericardial fluid in the blood trauma and maybe stable, maybe pericardial window is wide. So I think this is not sometimes you have to wait. Sometimes you have to observe the patient.
Luis Straceri, what do you think? Would you go to observation, pericardial window, or other idea?
Until this time, conservative management. Monitoring
Observation.
the patient, okay? And maybe, as Colleen said, another echocardiography hours later.
Then,
With this
Other
physical
idea.
explanation, exam.
Yeah, so
monitoring, observation, repeat it fast, but do not go to the pericardial window right now. Then what is your idea?
So,
yeah, so
Yeah.
at this point, I would do a pericardial window.
I'm sorry, Dan. I'm sorry, Dan. There is another comment from Ribeirão Preto.
I don't know if Gustavo agree with me.
Let me say something. Yeah, we've seen some patients like this in the past, and we used to take all of them to the OR, and sometimes all that we found was a small tear in the epicardial tissue. So no sutures, no stitching needed. Perhaps for this patient, we would wait a little bit longer and take him to perhaps cardiac MRI.
Oh, Gustavo, were you in the last SBITE webinar last Wednesday or not?
No, unfortunately, no. Yeah.
We received Dr. Garcia, Alberto Garcia from Colombia, and he spoke about this non-operative treatment for cardiac injuries, and it was very interesting to understand exactly what you said. So small tears may heal. They are not even giving these patients to the pericardial window, but this is not, worldwide approved approach. Yeah, let's hear again.
But I've seen it.
People from Miami, they do this conservative approach. It's not non-operative, okay? But how do you do this in Miami then?
Yeah, so I think it's very reasonable what Dr. Collet said and others. There's a chance that this may be physiologic and you have a negative window if you take him for a window. However, the problem is we want to know. So in our institution, fluid on the echo, stubborn in the box, that equals a pericardial window. The question is what you do know if the window is positive, right? So we have obviously the data from South Africa, where people just irrigate the pericardium, and if there's no persistent bleeding, the fluid clears up and there's no further bleeding, and the patient is hemodynamically normal. I will repeat, hemodynamically normal. You may consider just put a drain in and observe them, and only do a sternotomy. If there's signs of full thickness injury, signs of bleeding or coronary injury. But just to monitor without doing a window, I see how this is an option for a lot of places. So US is very litigious. So if the guy at 6 hours later goes into tamponade and now I have to do a crash OR case and he has a poor outcome, let's say a poor neurological outcome, I would have a problem from a medical legal point of view. So I think for sure it's going to get a window here. And while I'm in the OR, I would also subxiphoid window, and I would also put a camera in and look at the diaphragm and a laparoscopy diaphragm. The other option is, I presented a case a couple of weeks ago, is what Dr. Clay mentioned, to consider do a VATS. So if the patient is completely normal and you put a camera in the chest, you actually get very good view of the pericardium and can see if there's fluid in it or not. And you can see the diaphragm. But the standard approach, would be subxiphoid pericardial window and the laparoscopy to look at the diaphragm. Then I can rule out all injuries. If I did that right, I don't have to worry anymore, right? If I have a negative pericardial window, negative scope, we're done, right? You can basically discharge the patient the next day or something. But I would do a window in this patient.
Okay, that's sure. I brought this this paper, just comment on this, because I think the case, all case is much about discussing this point in which you have a small amount of fluid, you have a wound in the cardiac box, and we are today perhaps have three opportunities. The standard approach would be the precardial window, and if positive, you go to the sternotomy or thoracotomy. But there are the 2 points. First, the points of washing the pericardium and see what comes back, as Dan said, and then an non-operative approach, as people from Colombia proposed. And here is a paper from these guys together, Dr. Ordonez from Colombia, and also Dr. Navsaria from South Africa. And here you see patients, unstable patients go to the sternotomy or anterolateral thoracotomy. And if you have a hemopericardium or stable, let's say it's stable, in the US, here is fast, okay, fast. Negative or mild, go to the serial thoracic ultrasound surveillance. Here is called ultrasound surveillance. It's not an operative treatment. We go to surveillance by ultrasound. But if you have a moderate or severe amount of blood, go to the pericardial window. And then here is the point. If it's positive, they drain and they do not operate the patient if there's not blood coming out of this pericardial window after washing this. And this is a point for discussion. I think in the next years, we're going to modify perhaps our ideas. The prospect for work from Navsaria and South Africa is very well done, and it's difficult to really say something against it. But what happened, and in this process, we didn't choose that, but the evolution helped us to decide. Now you see here the dilated veins in the neck showing a pericardial tamponade, and the ultrasound showed an increase. This is the fast. We are doing the fast. We have an increase in the amount of blood, and there is some kind of tension. And being honest with you, we saw the right part of the right ventricle going, compressed, and justifying the hemodynamic compromise of the patient. Okay,
I'll say a quick question. Sorry to interrupt. What's the timeline here? How much was that after arrival? About
perhaps 6 hours.
6 hours. Yeah.
Perhaps that's because our echocardiogram, it's not made instantly. We ask for it. You have to schedule it, and if the cardiologist, is available, we can do this rapidly. And in this case, it was rapidly. But the worsening, if I remember, is just after some hours, 6 hours after the echocardiogram, almost. Most not. The patient remained with the blood pressure stable, but the heart rate was increased a little. And then I'd like to discuss what would be the options for this patient right now. Dan, can you start with that? What do you do with this patient right now after the echocardio and this evolution? We go to the pericardial window again?
That's clearly an operative case, and in terms of incision, sternotomy versus left thoracotomy, right? That's what we always discuss. I mean, if he's crashing, becomes hemodynamically profoundly unstable. The left thoracotomy is faster, and you still can get pretty well two ventricular injuries, left and right side. But if he's only tachycardia, his blood pressure is good, you probably would just do a sternotomy.
Sternotomy, yeah. Use the saw, or what do you use for the sternotomy? Yeah.
The saw.
Okay. Dr. Khalid, next step here. Would you go to a pericardial window, try to wash it, or go to the operation?
This patient may become with signs of cardiac tamponade. So it may be stable, but in 6 hours or around this, the patients may become with increase the pericardial infusion, increase the venous dissection. So, jugular vein, anterolateral thoracotomy. No pericardial window, no wash in this situation. The patients with the pericardial fluids increasing. So I think if you can go to make our pericardial window and wash, you can see blood, and probably it's not, it may be increased again. So I don't think this procedure is safe for these patients now. So I think these patients need to go to a thoracotomy.
Okay, let's stop the washing. Go to the OR and do a thoracotomy or a sternotomy. Luis Traceri, you and your guys here in Ribeirão Preto, what do you prefer? Which one you prefer?
Consensus rear, thoracotomy, yes?
Yeah.
Is this anterolateral or sternotomy? What do you prefer?
No sternotomy. We left incision.
Okay,
Anterolateral.
thoracotomy. That's here. So here for the students in the room, this here you have the fluid, the space between the liver and the heart, and this dark here is probably blood. And here is our incision. Yeah. The left anterolateral thoracotomy. Then I respect a lot people who prefer sternotomy, and I know in the United States, majority of the people prefer sternotomy. And we in Brazil, the majority of people do not have access to the electrical saw and use all the Lepschli knife or the Gigli knife, the Gigli saw. And for these, our results for sternotomy, they're not so rapid. And being very honest, the problem that I see with the sternotomy is that word more is about infection. The postoperative infection is really difficult to manage in sternotomies. It's not an excuse, okay? Perhaps it's a better decision. I'm not really discussing this, but I think the majority of Brazilian surgeons will go to this left anterolateral thoracotomy. As you see,
I think the left anterolateral thoracotomy is a great decision. I use it most of the time. I also prefer sternotomy. However, you know, there's one disadvantage, which is rare, obviously. But you know, if you let's say he has a coronary injury and needs a bypass, that's hard to do through a thoracotomy, right? And that's the only thing. I mean, the thoracotomy is for sure faster than the sternotomy, no matter how skilled you are, no matter how well you have a saw and whatever. You know, if a patient is unstable, we always do thoracotomy. You know, and that's most of the time the case anyway, right? Most of the time you operate because they're in tamponade. And the other thing I want to point out, right? He is normotensive now, right? But as soon as you induce, he will not.
Okay.
So once we go on positive pressure ventilation, the hemodynamics is going to change very quickly. So yeah, most of the time they're going to end up with thoracotomy.
Then, can you give us some technical tips for this operation? What are your tips to really get good access or something? Really, have the heart in your hands without making any injury to nerves or something like that.
Yeah, I mean, if you do a thoracotomy, I think the most important thing is that you prep and drape before you induce, because as I just mentioned, they're going to crash when you induce and when they have signs of tamponade already. So you want to be fast and then you just do a regular left anterolateral thoracotomy. And when you open the pericardium, you obviously have to be careful that you don't cause additional injuries. So I like to elevate the pericardium with a 2 hemostats or something, and then use a scalpel to do a little nick, and then use the scissors to extend it, and be careful to preserve the phrenic nerve on the left side. So you want to stay more anterior, not to lateral. If you have already the injury in the pericardium from the start one, if you see it, you can use it as your entry point. Just extend it with the scissors, but it's very important to not cause additional injuries, and that's sometimes a concern when you operate with the trainees, that they're a little bit too fast, and then cause an additional iatrogenic nick in the pericardium or on the at the muscle or at the coronary. So you want to be careful with that. And then it's pretty much straightforward in the thoracotomy. For the sternotomy, sometimes what helps if you elevate when you open the pericardium, you can elevate it either with stay sutures or on the retractor, and then kind of bring the heart a little bit more anterior into the field. But that's pretty much it.
Okay, Dr. Colette, do you see here in our picture, you're actually going through the sternum and transverse sternotomy that sometimes is necessary to expose the right side of the heart. Can you give us some technical tips on this?
Parreira, in this situation, where I see the injuries on these patients, I prefer to go to a sternotomy. I can use a knife or I can use a saw, but I think I prefer in this situation, in this patient, go to a sternotomy. It's very more easy to see the heart and no problem. Usually, the most part of the surgeons in Brazil who use anterolateral thoracotomy, maybe increase to a clamshell surgery, incision. But I think you can do by left anterolateral thoracotomy, but in this situation with small injuries, you can see only the heart in this situation. I think I go to a sternotomy. It's very more easy to fix, and to close the sternotomy is very easy. It's not very difficult.
Okay. Luis Traceri, any other tips here? What do you say to your residents? Well, let's prepare, let's prep, do it this way. Let me see.
Okay, so we would like always to be prepared for the worst case scenario. So we would like to be ready for a massive bleeding once we open the pericardial sac. So we would prepare the anesthesiology team. We had a lot of blood transfusion prepared for the patient. And always after anterolateral thoracotomy, personally, I like to use two retractors. One one each side to enhance my field, so I can be able to suture in a better situation.
Okay, my tip here is really open the left arm. Have eventually put some kind of pillow this way to do it, not a totally lateral thoracotomy, but gain perhaps 30 degrees to open your arm on the head as you're draining the thorax, so you open your space. The intercostal spaces are open with this and this gains some space. Some inches are really important in this situation. But being very, very honest with you, I have no problem in doing the transverse sternotomy. I'm just showing some parts here. What we had here, sorry, this is the heart, left lung, okay, left lung, superior, inferior lobes, lingula, and here is the heart. This is the right ventricle. And you see here, we made a transverse sternotomy, and this is the internal thoracic arteries ligated. This is the point. If you go to the other side, you have to ligate it, and it is absolutely necessary that you look for them after, because during all the stress of the active bleeding, perhaps they are not bleeding because the patient is hypertensive, but it's going to bleed in the postoperative period. So you have to find them and you have to ligate them if you go through the sternum. And we have here the wound. Of course, it's already suture. There are two U-shaped points with Prolene 3O, and use the pericardial as some kind of reinforcement here. So there are two U-shaped knots here, okay? Sutures, U-shaped sutures here, one here and another here. You can see better closer. This is the wound. It's not a small wound. I couldn't believe it. It was so so stable during so much time, because it was hours without the patient decompensating. It was really, there was a lot of bleeding. I don't have the film because I had to go in the field with the resident. So that's what happened. Any comments on the cardiac suture? Perhaps Dr. Colette or Dr. Luis, how would you choose the best way to suture this heart? Gustavo or Luis?
Oh, I think that's great. The sutures, any suture you can do, no problem with non-observable suture.
As long the bleeding is stopped, it's okay.
Yeah, yeah. Sometimes with a Foley catheter into the heart. Okay.
Okay.
Uh,
Have you ever tried to put the stitch with the Foley there? It just don't work because it punctures the balloon.
Yeah.
And it's well, can do it temporarily, but as soon as possible, you put your finger on and things, as you said, goes as the way it is. Any other comments?
we have the transportation with the finger into the cardiac and into the heart until arrive the OR.
Yeah. The finger is ahead.
Another point is the how long is the open in the pericardium? We
How
have
long?
to, the extension. We have making it open because sometimes we have patients that reaccumulate, retamponate the cardiac after 10 days because it was very little and it closed and retamponate.
So Dan, what's your idea? What are your tips here?
Yeah, first of all, it's a beautiful case, Jose. So thanks for sharing it with us. What's interesting, right? It's the right ventricle, so it's kind of a low pressure system compared to the left side, right? It's not as low as like in the atrium, but it's a great example to show that your right ventricular pressure is usually 50 over 30, 60 over 40. It's enough to cause tamponade from the right side. You don't need to have a left ventricular injury or a coronary injury in order to get tamponade. In terms of platelet on the left side, I routinely put platelets because again, it's a high pressure system. On the right ventricle, I'm not sure if you really need it or not. We usually try to put them also on the right side, but you probably don't need them on the right side. But I like to be on the safe side. I don't like sutures to cut through it. I also just use the finger to control it. I think it's much better. As you mentioned, the Foley balloon really doesn't work, and I've even seen cases where it enlarges the injury if you inadvertently pull the balloon through the injury. You make it bigger. So the Foley is not really working well. Sometimes people, if they do like an emergency room thoracotomy, they initially put staples to control it and then do a form of suture repair afterwards. Also not a big fan of putting staples. I think most of the time you can control it with digital compression and then put your sutures. The other thing is to be careful what's your relation to the coronary vessels, right? You don't want to inadvertently get your coronary artery, if it's close by, into the repair. So sometimes we have to do this, you do this U-stitch and go underneath the coronary and come out on the other side to make sure you preserve it. But that's pretty much it.
Yeah. How do you manage the pericardium? Here's the pericardium, it's open. Do you leave it open? Would you, try to approximate it? How do you do it?
No, I leave it completely open.
Open, yeah. That's the same for us. That's fine. Any other question? Kevin, I do not have access to the chat because I'm presenting. Okay, do you know if there is any question that you wanna put here?
No one has put anything in the chat.
Okay. If you want to leave your comments, please. Briefly, I'm going to finish the case and we're going to the chat. So the postoperative period was okay. after releasing the cardiac tamponade, the patient remained stable during the operation. Okay, there was a huge blood, bleeding during the operation, but the patient was no problem. We repeated the echocardiography in the third postoperative day with no internal injuries, because eventually you have fun, patient, when you feel a thrill inside the heart. No, you feel the heart in a thrill, and eventually you have some kind of interventricular communications. You have to ask for if the patient is stable, you wouldn't do anything, but usually the cardiac surgeons are called and they ask for the cardiography and things like that. Not for this case, okay? This case was pretty much okay. We drained bilaterally because the transversal sternotomy, sorry. And the patient was discharged, I'm sorry, 7 days ago, 7 days after, with no any problem. Comments on that?
Question, Jose, do you do routine postoperative follow-up echocardiograms to look for effusions, ventricular dysfunction, or you think it's only needed if the patient is not normal hemodynamically afterwards, or is anybody doing routine echoes on all cardiac repairs?
Routinely. Man, I kind of have a aspiration. Sorry. Routinely. People, Collet, Luis, would like to comment on?
Gustavo, congratulations for the cases. Cardiac injuries in the chamber, maybe valvular or maybe in septum. I have a case like this that has injuries in the septum. So I think it's very important to see an echocardiogram before the surgery, but these patients can be usually maybe close the pericardium and then the patient can be discharged. Not close hermetically, but can close the pericardium sometimes. So it was the chest drain. Not so. Congratulations for the case. Very interesting case.
Thank you. Thank you, Collet. The idea was pretty much discussing these new ideas on managing stable patients. But this case was really good because he arrived stable, but in a few hours he managed, stabilized and had needed the operation. Luis, can you do your comments?
Oh, thank you for this opportunity to discuss this case. We're asking here, why nobody thought about thoracoscopy as an approach? It's very important. We are old to not mention thoracoscopy, only thoracotomy.
We do a lot. We do a lot, but we do it for investigation. Yeah, we have. Thank you, Dr. Collet has to go. Thank you for our comments, Collet. Usually they were perfect. We do a lot, but we do it as a diagnostic procedure. If you have a left hemothorax, the best way to rule out a cardiac injury and diaphragmatic injury is through the left VATS. So we do it a lot, but not for therapeutic. We do not do it for a therapeutic means in the heart. I'm not sure about Dan. What do you think about this, Dan?
Yeah, so we just did a thoracoscopy on a patient who came in with a knife in place inside when she arrived in the left chest, completely normal hemodynamically, and normal ultrasound in the trauma bay. And then when we opted to do thoracoscopy, put a camera and see where the knife was, the tip of the knife was actually not in the heart, not in the pericardium, away from the pericardium, and you can see everything beautiful. You see the pericardium, you see if there's any pericardial injury, if there's any blood behind the pericardium, you see if there's any lung injury, lung highlight injuries, and you see the diaphragm, as you just mentioned. So it's a perfect method to do it, but for diagnostic reasons, not on unstable patients like this one who is in tamponade. There's no role for minimal invasive in my mind. When you have hemodynamic instability and ultrasound findings of tamponade. But congratulations for an amazing case. I think it was a very good discussion. I think this case again shows that you can come in hemodynamic normal and initial negative fast exam. I think that's why it's important to do a formal echocardiogram and to observe those patients. And if you opt to do not a window because you think the likelihood of cardiac injury is low, those are those cases who remind you, but even patients with normal vital signs and initial negative fast, and you didn't see any blood, no hemothorax on the chest X-ray, doesn't mean that they still can have a cardiac injury and become symptomatic and then require emergency surgery several hours later. So it just undermines that you have to have a very high level of suspicion, be very cautious, don't send those people home, observe them, do the serial ultrasounds if you opt not to do a window, and go from there. But it's a great case. Thank you so much for sharing it with us.
Thank you, Dan. Thank you, Luis. The point is really, we are really facing this perhaps a change or challenge of our paradigms on these patients, and we'll need some extra data for non-operative treatment, because some of these patients, they unstabilize during the next hours, but they didn't say for us to send them home. They say admit and monitor and repeat ultrasound. That's what they say. And next, this patient would be very well treated in this situation too. So thank you very much for that. I think the goals of this meeting were achieved, and mainly because of your comments. Thank you, Dan. Thank you, Luis, Gustavo, Collet, and anyone who is participating here. Thank you very much for that. Thank you to Pan American Trauma for the opportunity, and for us, SBITE, it's an honor to participate in this meeting. Thank you.
Thank you. I hope to see everybody in Ecuador soon.
Oh, unfortunately, I'm not coming. But many SBITE people, they are going there then. Unfortunately.
Awesome.
Thank you.
All right. Take care. Bye-bye.